July's Community Enrichment Series. I'll be doing Medicaid 101, so the basics of Medicaid benefits, programs, common terms and acronyms you may have heard. So some ground rules. This presentation is being recorded. Questions and answers will not be recorded. So when I'm done, we'll turn off the recording and then I'll answer any questions. Please remain on mute. Use the chat to submit your questions and then we'll address them at the end. This is a safe space, no judgment. If you are a current client, you receive services from us, this will not affect your services. This is confidential. Any questions you have to ask or you want to ask. If you do, try not to share any personal information, but if anybody hears any personal information or opinions, don't share it outside of here. It is confidential. Please silence your cell phone if you are not on mute. And slides, documents, unanswered questions will be emailed later. So disclaimer, I don't work for Medicaid. I've never worked for Medicaid. This is for informational purposes only. It's not a substitute for advice or eligibility determination. My presentation here is based on my experience at the coordinating center, not from Medicaid. My name is Sharon King. I'm currently the Senior Vice President of Population Health at the Coordinating Center, so I oversee most of our programs here. I've been here for 31 years. So I started as a model waiver coordinator, and that was our first program. So I have implemented all the programs that we have had since, and most of them have been Medicaid programs. So that's where a lot of this information comes from. The objectives, you'll gain a basic understanding of Maryland Medicaid programs, be able to gain a basic understanding of how Medicare, Medicaid, SSI, and SSDI all relate to each other. And you'll have access to some resources to determine whether someone's eligible and how to apply for Medicaid. So basic definitions and differences between Medicaid, Medicare, SSI, and SSDI. So Medicaid was created in 1965. It's public insurance that provides healthcare coverage. Most people think of it as for low-income families, but it's also children, parents, pregnant women, seniors, people with disabilities. There's a lot of different eligibility categories. It's jointly funded by federal governments and the state. So the government sets certain guidelines, and then each state has some flexibility of how they can structure it and the different programs. That has to be approved by the federal government, which is CMS, Center for Medicaid and Medicare Services. So as a result, Medicaid can be different from state to state. Medicare is federal health insurance program. Generally, people think of it as for older people, seniors over 65. But it's also for some younger people with disabilities and people with end-stage renal disease and people with ALS. What's the difference? So Medicaid is administered by states under federal CMS rules and guidelines. Medicare is administered by feds. So it's the same regardless of where you live in the country. Medicaid can vary from state to state. Medicaid is income-based. Medicare is not income-based. Medicaid is minimal or no cost to the individual. Medicare has co-pays and premiums like other insurances. Medicaid is the payer of last resort. So if you have other insurance, Medicaid is the last payer. Medicare is usually the primary payer. If you have other insurance, you speak to them, they do a survey, they figure it out. But it's usually Medicare pays first and your other insurances pay last. Medicaid, you become eligible with SSI, and Medicare, you become eligible with SSDI, which I will go over next. So SSI is administered by Social Security, but it's a different fund than what we pay into as we're working. So it's for those who are disabled, blind, or at least 65 years old with limited income. Many states, including Maryland, when you get SSI, you get Medicaid. So eligibility is different for children and adults over 18. For children, there's an income requirement and it looks at the family's income. So you'd have to have a disability and then this income requirement. Once you're over 18, regardless of who you're living with, you apply on your own. So it's only based on the individual's income. So they'd have to have a disability and then it would look at their income. The amount received is based on the amount and the type of income. And then again, in Maryland, you get Medicaid with your SSI. SSDI is insurance. So it's Social Security Disability Insurance. It provides benefits to individuals or family members, sometimes family members, if you're insured. So being insured means we've paid into it. So we would have worked and paid into Social Security. The amount of time you have to work really depends on the age, but it's usually at least 6 quarters. The Medicaid benefit, Medicare benefit begins 2 years after receiving the benefit. Unless it's end-stage renal disease or ALS, they do not have to wait the 2 years. Others have to wait 2 years. Now, from what I hear, if you've known anybody who applied for SSDI, it's often denied the first time unless it's really like a terminal diagnosis and it's really obvious. So many people they get the denial, they have to fight it. Sometimes they get a lawyer, and that process can take a while. And sometimes it's 2 years before they get their SSDI, but it would go back to the date and then they would get Medicare. But the idea behind it is they decided to wait 2 years when they first implemented SSDI getting Medicare. And some of it was for cost for Medicare. And some of it was they really wanted it to be people who would have SSDI for 2 years. That would be people who really have long-term, more severe disabilities. And the thought also was when you first apply for SSDI, you may have other insurance. So there's that 2-year wait. But again, for end-stage renal disease and ALS, they do not have to wait the 2 years. So the differences, SSI, you do not need a work history. So we tend to see children with disabilities get SSI. So SSDI, you need that work history. So that's more adults who have worked and then become disabled. SSI, it is administered by Social Security, but it's a different benefit. It doesn't come out of the fund that we're contributing to when we work. Social Security benefit, SSDI, is for individuals who have contributed to that fund. For SSI in Maryland, you get Medicaid, and SSDI, you get Medicare. You can get both. So if someone were to apply for SSDI, and that's based on how long you worked, and just like our Social Security at 65 or 62, whenever you decide to retire, it's based on how much you made and how long you worked. So this is similar. So if you didn't work for very long or you weren't making much money and your SSDI amount is low, you could qualify for SSI if that SSDI income falls within SSI income requirements. So now I'll go over Maryland Medicaid. So health choice, fee-for-service, waivers. And first I'll go over eligibility. So eligibility, like I said, there's a lot of different categories. So generally, those who get it for living for low income are at 138% or lower of the federal poverty level. So for 2024, a household of one, that's $20,783 a year. Some categories have limited assets. Some of them don't look at the assets. SSI recipients, spend down. We don't see a lot of people with spend down in our programs because generally they don't go into some of the programs. Spend down means your assets might meet the requirement, but your income is just a little bit over. And you have a health condition where the amount that's over, you would spend. So let's say I made $500 more than the income requirement for Medicaid. If I submit $500 worth of medical receipts, then that for the rest of the time period, I would have Medicaid. And I believe they did, or they used to do 6-month time periods. So these individuals, some of them may spend that money right away. It might just be a little bit, spend it right away, and they get Medicaid for most of the time period. And other people might only get it for the last month. So for that reason, they don't tend to go into programs because they would be popping in and out. Then there's MCHIP, Maryland Children's Health Program. That was around even before like the healthcare exchange where we all needed to get insurance. This was to encourage all children to be insured. And there is somewhat of an income requirement, but there used to be premium. So it was kind of a sliding scale. If you made a certain amount of money, you had to pay into it. That kind of went away through the pandemic, but it was official in May of 2024 where they don't pay into it. So I don't even know if they call it premium and non-premium anymore. It's just Maryland's Children's Health Program. It's often for people who either they work but can't afford the insurance in their company, or they're self-employed, things like that. So it's for children. It's called MCHIP. Individuals, children in foster care, and then waivers, which I will explain a little bit later. But there's so many different eligibility codes, and this QR code will bring you to a chart. And Heidi is gonna, so here's the chart. So it's a little overwhelming. There's a lot of different categories, and each category has a coverage group. So we will soon scroll down and I'll show you the different categories. So there's adult expansion. So that happened again with the healthcare exchange several years ago. It used to be that you only got Medicaid if you had a family, if you had children, so they expanded it to adults. So that's the adult expansion population. And then the category for age, blind, and disabled. Then there's 2 demonstration programs. Heidi, as you scroll down a little bit, demonstration programs, they're kind of like pilots. And then there's children who are age blind and disabled. I believe that's no, age blind and disabled in long-term care. And then there's the children categories, and then children in long-term care, and then family planning, foster care and subsidized adoptions, home and community-based service waivers, which I'll explain in some of the few slides coming up, parents and caretaker relatives, pregnant women, presumptive eligibility, inmates, and if you go into the hospital, you can get Medicaid earlier than having to wait. So there's this presumptive eligibility. Refugees, transitional medical assistance, the specific acts, Walter Lomax acts for individuals erroneously convicted. So there's all these other little categories that we don't see a lot of people in, and then emergency services. So on this, there's a lot of acronyms. They're all defined at the bottom. If you want to go up. So you can go back up to the top. So as you go across the top, Medicaid eligibility criteria. So they have the age limits to each category. FPL is federal poverty level, so it's the income limits. If there's any asset limits, and whether there's other criteria like disability or some kind of medical technical. The income methodology is MAGI is modified adjusted gross income. So that's if they're actually looking at your income. And then the non-MAGI means there's either a special formula or they're looking at something else. The Medicaid eligibility, the green part, is who determines whether you're eligible. So it's depending on how you're eligible, it's different systems. And then there's the system owners, who owns that. And the points of entry would be important for you. But when I go over applying, I always start at Maryland Health Connection. And if you have to apply somewhere else, they can let you know that. But it's also in this chart how you could apply for Medicaid. Okay, we'll go back to the slides. Applying for Maryland Medicaid, again, it depends on the eligibility category. First stop, I would go to marylandhealthconnection.gov. If you go on their website, you can also go in person for each jurisdiction. They have places that you can go and talk to someone in person. They're the local connectors. And you can really go to any Department of Social Services if you're applying for something. If you're low income and you're applying for something for the first time, you can apply for all kinds of things at once. You can get your food stamps and your Medicaid by going to DSS, Department of Social Services. So then what happens when you get your Medicaid? Previous to 1997, it was fee for service. So fee for service is I go to the doctor bills Medicaid, a nurse comes to my home, they bill Medicaid, the pharmacy bills Medicaid. And around 1997, Maryland Department of Health, who administers Medicaid, said, yeah, no, we're not going to do that anymore. We're going to pay managed care organizations, and they're going to have the providers, and they're going to pay the providers, and they're going to decide who gets what and what gets approved. So that's the MCO model started, and they call that health choice. So MCO is like an insurance that we would have, but it's called a managed care organization under Medicaid. So once somebody's enrolled in Medicaid, most people choose an MCO, and if you don't choose your MCO, you're auto-assigned. These are the current Maryland Medicaid MCOs. And when you get these slides, these are links. So if you click on each one, it will tell you about the different MCO. And if you have Medicaid and you're trying to choose your MCO, it would just be like when we get different options, we look at who's our most important provider, who's the doctor that I can't switch. You could call them and ask them which one they accept, or you could go on each site here and see. So those who do not, I said most people have to choose an MCO. Some do not go into the health choice MCO model. That's those who are receiving Medicare, 65 years or older, also because they would be getting Medicare. If they're eligible under spend down, remember I explained they kind of pop in and out of Medicaid, so they would not go into health choice. If they're in one of the smaller, like family planning programs, some of those smaller categories, they would not go into health choice. Some of those categories, they don't get full Medicaid, they just get limited benefits. If they're in an institution, they're not in health choice, they have long-term care Medicaid and the model waiver program, because that was created before health choice and they tend to just leave it alone. So REM. So like when I was explaining the MCOs and how you choose your MCO, you would look at what are the most important providers that I have? What are the most important physicians, the ones that I can't switch? And you would pick your MCO. Well, when they were developing this MCO model, they were aware that there were people with very complex conditions out there who had a lot of providers. They could have 8 to 10 specialists. They had a nursing agency, an equipment company, physical therapy, pharmacy. And the chances that they were going to find all those providers in one managed care organization was pretty slim. And they didn't want to disrupt all that for these individuals. So they came up with REM. And so it's a carve out. They're in health choice, but they don't choose a managed care organization. They get fee for service and case management, which is currently provided by the coordinating center. And they get the flexibility to use any Medicaid provider. So they could keep all their providers and not have to be disrupted by being forced into a managed care organization. I believe it was initially temporary, because I guess if you were newly diagnosed with a condition, you would choose within your MCO, but it has continued because when they talked about putting it into managed care, everyone flooded down to Annapolis, and I don't think they'll try that again. So they plan to continue with REM. So if you're visual, under Maryland Medicaid, most people go into health choice, and in health choice, you choose your MCO, or if you're eligible for REM, you can go into REM. To be eligible for REM, you have community Medicaid. There's a list of about 300 and some diagnoses, and each diagnosis has an age range for when that diagnosis would have a lot of specialists and be high cost. So you would not need to go into an MCO. you could go into REM. Other people who do not even go into health choice and are just plain fee for service are those that are duly enrolled in both Medicaid and Medicare, those in spend down, and those in model waiver. So a term you may have heard is EPSDT, Early Periodic Screening, Diagnostic, and Treatment. So basically, it's a law that all states have to provide these comprehensive services for all children in Medicaid. And the purpose really was so that all children get screened, diagnosed, and treated as soon as possible for specific conditions, or for any like childhood condition. But as part of the treatment, all these services in the purple box have to be, regardless of what state, all Medicaid has to have these services available to children. So when they call it an EPSDT service, typically it's a Medicaid benefit that's available to children, but is not available to adults when they turn 21. So if you've heard that term, that's what it means. Sometimes people are in programs. So let's say model waiver. It's not really a waiver benefit until they turn 21 because it's a state plan, what they call state plan benefit. Like anybody in model waiver or anybody in Medicaid under 21 can have access to these services. Private duty nursing is typically the one we hear it referred to for model waiver and in REM. And so they'll call it EPSDT nursing because it's really a state plan benefit. After they turn 21, it's available to them as adults because they're in that program. So then they would get it through, it would be a waiver service, or in REM, they called it an optional service. So that's why you may hear EPSDT. Now I'm going to go into some of the waivers, and they're called home and community-based waivers. So what is a waiver? So the coordinating center started, we were one of the first waivers. So model waiver was the first waiver in Maryland. And that came as a result, the coordinating center was already working on a grant that was very similar. And meantime, there was a girl named Katie Beckett. And Katie Beckett had an infection in her brain, which really affected all of her systems. So she was hospitalized long-term. When she was stable, she was a toddler. I don't remember her exact age, and I'm sure it was a while before all this happened. So she was stable enough that her mom wanted to bring her home. She was on a ventilator when she was sleeping, but that meant that she had a tracheostomy, she had a G tube, she had some mobility issues. So she definitely had care needs. Problem was, when you're in an institution, when you're living in a hospital or any facility, after 30 days, that becomes your residence. So Katie, as an infant, then qualified for Medicaid because she wasn't living with her family. So they didn't consider the family's income. It was just her income. But if her mom brought her home, she would lose that Medicaid. So who's going to pay for the home care? Medicaid was paying for the institutional care. There'd be nobody to pay for the home care. So she brought it all the way to Washington, and Reagan at the time realized we have children all over the country stuck in hospitals, institutionalized, because if they go home, they're going to lose their Medicaid. It's better for them to be at home. It's usually cheaper for them to be at home. How can we make this happen? So that was the first waiver. And it was based on, so our current model waiver is based on the fact that these children would be living in institutions with Medicaid, but would not have Medicaid out in the community. So only the child's based on the child's income. And most of them have insurance now, but their insurance usually doesn't have a benefit that would meet their needs to keep them at home. Usually it's private duty nursing. So if your insurance policy doesn't have a private duty nursing benefit and you need private duty nursing, or you would be living in a hospital, then that child could come on to the model waiver. So that's how waivers started, having community-based waivers. They're all to get people out of institutions and into the community. They have to be cost neutral. It can't really cost more money for them to be out in the community, and it's usually not. But each waiver targets a specific population, and it's not always making them eligible for Medicaid. Sometimes it's what services do they need that other people in Medicaid can't get. So it's all based on what would make that population be able to live in the community instead of an institution. So they get different services than the usual state plan services, and eligibility might be a little bit different. Next slide. So here's Maryland's home and community-based waivers. We have an autism, the ones in purple are the ones that the coordinating center currently provides coordination for. The ones in blue, we do not. So the autism waiver is a waiver. It was intended to deinstitutionalize or prevent institutionalization now for individuals with autism. So because it is deinstitutionalization, it's people with moderate to severe autism, and that's determined through the school, how many services they get through the school, and there's a school psychologist. And it is based on the child's income, similar to model waiver, and there's additional services that are specific to individuals with autism that would enable them to live in the community. The community options waiver is for individuals living in nursing facilities, or some people call them nursing homes. We call them skilled nursing facilities. There used to be one for younger adults, one for older adults. The younger adults was living at home. They combined them into two, and that's the community options waiver. So that's for individuals who are living in nursing homes, nursing facilities. And what they need is a home to go to. So if they don't have one, we have a housing division that helps them to find a home. And then there's some funds that helps them to move into that home. Because when you're living in a nursing facility, they basically, whatever income you have, they take and give you, a small subsidy. Not enough that would give you basic necessities till you got your first check. So we try to discharge them towards the end of the month. And then they have this as a benefit through the waiver to pay for some of those things. But then it also pays for things like personal care attendants, somebody to take care of them. Most of them ended up there because there was nobody that could take care of them. There's home delivered meals, there's technology that would assist in the absence of a personal care attendant and things like that. There's also other programs that are kind of part of that umbrella that are not waivers. So when they combined the older adult and the younger adult waiver and made it community options waiver, they also introduced what we call community first choice. And that's to prevent people from going into nursing facilities. So that's another one that's not a waiver. It's just a home and community-based program. Model waiver is the Katie Beckett waiver. So I explained that's for children who would be living in, say, Mount Washington, HSC. And it provides, they can live at home in the community instead with Medicaid paying. DDA has 3 different waivers, and that's DDA is for people with developmental disabilities. And that's for individuals who used to live in what they call ICFI, Intermediate Care Facility for the Intellectually Disabled, ICFID. Most of them, we've closed most of them down. That was like the Great Oaks and all. And they go into one of these waivers. The Community Pathways waiver is for adults who also need residential, so they live in group homes or supported housing. Community supports waiver is for adults, but they're going to continue to live maybe with family members, and they get community supports. And family support waiver is for children. The brain injury waiver is exactly how it sounds. It has pretty strict criteria. I think you have to be from the state institution. So we do not, that's run, I think, by Behavioral Health Administration, maybe. So we do not, that's a small waiver, obviously, for individuals with brain injury, adults. And then the medical daycare waiver. So medical daycare waiver services and all these waivers get federal matches. So the state pays and then the federal contributes to it. So medical daycare is in most of these waivers so that they can access that as a waiver service. But if somebody is not eligible for any of these waivers, there is a medical daycare waiver that would just basically make them eligible for medical daycare. Next slide. So that's pretty much it for my presentation. These are the references that I used to get facts. And then the next slide is resources that you can use. So Maryland Health Connection, there's also that QR code on one of the slides, but there's the link right there. There's the Maryland Medicaid Blue Book, which explains home and community-based